Good morning, everyone. So I'm just going to give you a little idea about the surgical tips that maybe in the beginning one must follow and later on can refine by its own strategy to come to good results. So toric IOL surgery is basically a learning curve which requires little of time, dedication, and observation of the results that you carry on. Um, each and every patient has to be analyzed at what has happened and what more has to be improved upon. Target hematopia, lot many things have been discussed. The important issue, like we were discussing, that 3 millimeter zone is the ideal zone to calculate the K reading, and that has to be a consistent K reading. Check any uh, aberration or maybe compared with the topographer if it is available, but it's not always mandatory that you can have a 3 millimeter zone K reading with your autorefractometer. Keep on doing cases and try to assess the things what exactly is going on. Dry eye disorders, they keep on changing the keratometry, so always put a lubricating eye drop and try to see that the 2 or 3 readings are practically similar. Optical and immersion biometry has been stressed upon, and the newer generation formulae, which are very important. Check and recheck the data. Feed it in software. Do it by your own. Maybe if your paramedical staff is doing, he might be putting access here and there, the surgical induced astigmatism, and take a proper printout, check it, sign it, and stick in your OT so that you're never going to miss anything, and you're definitely on a target. Counseling of these patients is very important because you in the beginning might be getting little bit of surprises. So to evaluate surprises and to make it more refined, the counseling is very important. No one is, I mean, say, 100% perfect because human eye is a biological thing. It's not like a computer. Some preoperative examination, the important are pupillary dilated in examination, the pseudoexfoliation, zonular weakness, or any retinal pathology, because you need to give a clear emmetropic 6/6 vision. This already has been discussed, but nowadays with the practice, I will say, doing more of a freehand marking. You ask a patient, put a Paracaine eye drop, ask him to look straight ahead, and with the freehand marking, you just do a 3 marks, 180 degree apart and 90 degrees. So this makes practically the things easy. But initially, in the beginning, you need to take a help of gadgets and keep refining. Finally, you'll come to this stage when you can do all this freehand marking. And this is practically equally good that we find in our results. Now, the important thing is the capsular axis. So just for the beginners, what exactly is important, take a ring, make a mark of 5 millimeter, or you can simply take a caliper of 5 millimeter, mark a central point of your reflex. So that will give you an idea that this is the limit of a capsular axis. So this capsular axis definitely going to cover the IOL and not going to keep the edge of an IOL free of the axis. This is what important, particularly in toric IOL, to make it stabilize longer in its axis to give you the best results. So this could be practiced in the beginning, but later when you get more accustomed, definitely you can go ahead with the way you like, and you can definitely take a proper diameter of a capsular axis, which is around 5 millimeter. Now, what more has to be observed in these cases? You get different variety of density of the cataract. It could be a soft cataract, it could be a hard cataract. Use your best method of doing phaco you are accustomed with. So it should be, I mean, say, like a normal phaco. The only thing you have taken axis where the IOL has to be aligned and the reference marking has to be good. Rest everything is practically same as a normal phaco. So never hesitate to do toric IOL in a way that it is a kind of fear for you. It has to be done in a normal phaco. These markings has to be very perfect. So like this is a little bit harder cataract. The axis reference marking and the alignment axis has been marked, and I usually sitting on a head of a patient. I usually take around 110 or 120 degree of my incision. Always try to protect the endothelium because you need to give a good clear cornea next post-operative day. So these viscodispersive agents are one of the good thing. The care has to be taken. You should not stress to the zonules, should not give any stress. If at all there's a zonulolysis or there's a zonular deficit while doing a phaco, you can definitely implant a CTR. And simultaneously, a safe implantation of IOL is all mandatory. It should not be with any jerks. It should not press too hard to the back. The normal way which you doing in a normal phaco. The only thing finally comes with a kind of alignment of IOL to axis required as far as the calculation or according to the calculation which has been done. Like in this case, this has been here somewhere around 80 or 75 degree of placement. Remove viscoelastic behind the IOL, which is very important because you need to make this IOL fix and adhere to the posterior cap. So this is very important. One can use a bubble on top of IOL after aligning it so that it remain praised with the posterior capsule. The other thing which is to be avoided is a hypotony. The hypotony is, if at all is there, it can allow IOL to rotate in the back. So these are the few tips which definitely has to be taken care of. And to move IOL in a axis of alignment while the irrigation aspiration is going on, one can take advantage of this second instrument and can bring it to the axis of alignment. So this could be, leave it just around 5 to 10 degree before of that